Many thanks to the Planning Committee for the opportunity to present the 6-year update of the FROST Cryoablation Clinical Trial. I'm Dr. Dennis Holmes. I have no personal financial disclosures. However, I designed and wrote the study protocol and served as the principal investigator of the national trial and site investigator of 2 different study sites. The trial was sponsored by Sonoris Medical between 2016 and 2020, but funding ended in 2020 when the company that acquired Sonoris discontinued funding. Background. Advances in breast cancer screening and genomics have enabled de-escalation of breast cancer therapy and increased interest in minimally invasive options like cryoablation with the goal of avoiding the risks and inconvenience of breast cancer surgery. The freezing instead of resection of small tumor trial, or the FROST trial, is an IRB-approved, prospective, non-randomized, multicenter study designed to evaluate the efficacy and safety of cryoablation for stage 1 breast cancer. The primary endpoint of the trial was 5-year local recurrence rate, with local recurrence defined as a recurrence of cancer within 5 centimeters of the cryoablated tumor or within 5 centimeters of the original biopsy site marker. The study was open to women aged 50 and older with ultrasound visible, unifocal, invasive ductal carcinoma. Tumors had to be 2 centimeters or smaller, assessed by imaging. Tumors also had to be hormone receptor positive, HER2 negative, and clinical node negative. They also had to be at least 5 millimeters from the overlying skin surface so that we could minimize the risk or potential risk of skin injury. The study population was divided into 2 age-based risk strata. Stratum 1 included women aged 70 and older who underwent cryoablation but no subsequent radiotherapy and also did not undergo sentinel biopsy. Stratum 2 included younger women aged 50 to 69 who underwent cryoablation, were prescribed radiotherapy, but were not required to undergo sentinel biopsy as it was optional for these patients. Both strata were prescribed endocrine therapy and also underwent an ultrasonographic core biopsy of the cryoablation site 6 months post-cryoablation. The accrual goal for each stratum was 105 patients. Cryoablation was administered in the office setting or in the radiology department using a 10-gauge cryoprobe and liquid nitrogen, which achieved a core tumor temperature of minus 170 degrees Celsius and an ablation volume of approximately 3 by 5 centimeters. Key procedural steps included ultrasound localization of the tumor, ultrasound-guided injection of local anesthetic, ultrasound-guided insertion of the cryoprobe through the longest axis of the tumor measured in the horizontal plane. Cryoablation was then initiated using a freeze-thaw-freeze cycle, with each freeze cycle spanning between 6 and 10 minutes based upon the diameter of the tumor. And overall procedure time from start to finish was generally less than 1 hour. Patients subsequently underwent an ultrasound-guided core biopsy of the cryoablated cancer site performed 6 months post-cryoablation. All biopsy results showed no residual cancer. Patients then went on to follow up for 5 years, including physical examination, serial imaging, and adverse events assessments. 93 patients were registered for the trial. There were 6 screen failures. 2 patients withdrew prior to undergoing cryoablation, and 2 patients were lost to follow-up, leaving 83 patients in both strata that were valuable for long-term outcomes. These patients were enrolled at 12 different study sites. Here are the patient baseline characteristics. The majority of patients were Caucasian, about 80%. In terms of age, the median age of stratum 1 was 76. The median age of stratum 2 was 62. And when both strata were combined, the median age was 71. All the tumors were invasive ductal carcinoma. All were hormone receptor positive. All were HER2 negative. About half were low grade. About half were intermediate grade. About 3% were high grade. The median size of stratum 1 tumors was 9.5 millimeters. The median size of stratum 2 cancers was 9.0 millimeters. Overall, the range of tumors was roughly 4 to 19 millimeters. Here are the treatments rendered. 48 patients in stratum 1 underwent cryoablation, of which 89% received endocrine therapy. 35 patients in stratum 2 underwent cryoablation, of which 86% received endocrine therapy, 74% received whole breast radiotherapy, 65% received both endocrine therapy and radiotherapy, 6% declined both endocrine therapy and radiotherapy, and about 11% or 4 patients underwent a sentinel biopsy, all of which revealed no evidence of metastatic carcinoma. Here are the long-term follow-ups. The follow-up for stratum 1 had a mean of 5.9 years. The follow-up of stratum 2 had a mean of 6.3 years, and the overall mean follow-up was 6.1 years with both strata combined. There were 3 true local recurrences. 1 local recurrence occurred in stratum 1, 2 local recurrences occurred in stratum 2, and in both occurrences within stratum 2, the patients had declined breast radiotherapy. All the recurrences were outside of the cryoablation zone. There was 1 distant recurrence that occurred in stratum 1. This is a patient who had a recurrence 6.4 centimeters from the cryoablated tumor, and thus this did not count as a local recurrence by trial definition. It is notable that this patient also declined radiotherapy and endocrine therapy. There were 2 axillary recurrences, 1 in stratum 1 and 1 in stratum 2, and the patient with the axillary recurrence in stratum 2 had also declined endocrine therapy and radiotherapy. There were no breast cancer deaths, and there were no distant recurrences. Here's the numbers we've all been waiting for, the 5-year local recurrence rate. And remember, there were 3 local recurrences that were considered true local recurrences. 1 occurred in stratum 1, yielding a 5-year local recurrence rate of 2.08%. There were 2 recurrences in stratum 2, yielding a 5-year local recurrence rate of 5.8%. Remember, both patients in stratum 2 who experienced a recurrence had declined radiotherapy, and 1 also had declined endocrine therapy. Overall, 5-year local recurrence rate for both groups combined was 3.64%. Here are comparable trials of patients who underwent breast-conserving procedures, both lumpectomy and cryoablation, with no subsequent radiotherapy. These specifically are trials that have 5 years of follow-up that are published. You see both cryoablation and lumpectomy trials. Once again, the FROST trials are shown in yellow. The local recurrence rate of 5 years ranged from roughly 2 to 4%, which places these recurrence rates right in the middle of the pack of breast conservation trials in which radiotherapy was omitted. You see the FROST trial or at 2 to 4%, and the ICE3 trial at 4.3%. There were no serious adverse events attributable to cryoablation or radiotherapy. There was also only mild to moderate side effects notable, meaning mainly mild to moderate pain, which is manageable with Tylenol, generalized bruising, edema of the breast or swelling of the breast, and mild erythema of the breast. There was 1 case of an axillary skin infection, which was managed with oral antibiotics. The main limitation of the cryoablation trial, the FROST trial, is that the study did not meet its accrual goal of 210 patients. We did, in fact, enroll 83. Premature closure was a reason for failure to achieve the accrual goal of 210 patients. Unfortunately, this potentially limited the statistical power of the trial and also potentially impacted the local recurrence rate determination. The conclusions of the FROST trial is that the FROST trial adds to the growing body of evidence supporting cryoablation as a safe, minimally invasive alternative to surgery for stage 1 breast cancer with 5-year local recurrence rates comparable to those seen with lumpectomy. The FROST trial also provides evidence supporting the selective use of cryoablation in younger women, women as young as age 50, and larger tumors up to 2 centimeters, as well as underscoring the importance of adjuvant radiotherapy for these women and adjuvant endocrine therapy for these women. I want to thank my trial investigators who continue to provide long-term follow-up with patients despite the loss of trial funding. And most importantly, I want to thank the patients who committed themselves, their time, their breaths, and potentially their lives to establishing cryoablation for these patients as a viable and safe option for management of early-stage breast cancer. Thank you very much.